Hi, everyone. Good evening. Hope everyone is doing well, staying healthy and safe. My name is Gabrielle Mauro. I'm from Patient and Family Centered Care at North Shore University Hospital, and I have Dr. Athos Patsalides here today to present to you guys. We hope you're all doing all right. And I just want to let you guys know before Dr. Patsalides begins that I will be holding a therapeutic support group like we discussed in the past. It's probably going to be on Tuesday, July 6th, again at 5 p.m. A reminder, this will be the therapeutic support group. It's not going to be educational. It's solely for you guys to discuss how you are coping with IIH. So if you're interested in that, please let me know. Send me out an email. If you don't have my email, I will send it out to you. Right now, we do have an IIH support group through Northwell, but I'm having trouble with receiving emails. So again, you could just email me directly. So let me know if you have any questions, concerns, and reach out to me. And without further ado, I will hand it over to Dr. Patsalides.
Thank you, Gabrielle. Just to clarify, are they going to send emails to your personal email?
Yep, they're going to send to my personal email for now.
Okay.
I'm going to send it to you. Yep. Suri, I see your message. I will send you my email. I'm going to send you the IIH email as well. But right now, because we're having some issues, you could just send it to my personal email since we're having some technical difficulties.
Okay, I'll get started.
Yep, go ahead, Dr. Patsalides.
Good evening, everybody. So this is the third session, educational session, and I decided to spend more time on questions that were submitted by emails. So it's going to be the first 30 minutes. I'll discuss 3 topics that are like what I call like unusual scenarios. And then I will go over like 10, 15 questions that were submitted via email. Again, thank you for participating. I think it's important to me, and I think it's important to the patients that we help each other understand the disease and the questions that arise from patients and the information provided by doctors. I think it's one of the satisfaction of working with patients with Patsalides is that they're like very educated. They answered the right questions, and I saw patients today that were basically asking the questions that I would be asking, if I were the patient. So that is like makes my work easier. Without more delays, I'm going to talk about pediatric IIH and venous sinus stenting, about jugular vein stenosis and Csf leak. Starting with pediatric IIH, it's essentially a difficult topic because number one, it's a rare diagnosis. And it's difficult to reach that diagnosis in children who suffer with headaches, but they don't have papilledema. So that is, that's a hurdle in diagnosis anyway. Then what is normal opening pressure in children is still debatable. It's somewhere between 25 and 28, but there's many pediatric specialists who think like 28 is of centimeters or 280 millimeters. These two are basically the same thing. 28 centimeters or 280 millimeters is the same value, is the same, is exactly the same number. So there's a lot of spinal taps that are like in the borderline area between mid-20s to high 20s, and that makes things a little more difficult sometimes to make treatment decisions. It's difficult to do a lumbar puncture in a child, especially like younger than like, let's say, 11, 12 years old without any sedation. And sedation does affect to some extent the intracranial pressure. So again, it's another of the difficulty with dealing with children with IIH. And then if we are considering stenting, the manometry, the measurements of pressure within the veins and on the 2 sides of the narrowing, which is an important tool in deciding stenting, that is difficult to do without anesthesia or at least without sedation in younger children. And that also affects the measurements. So there are some inherent difficulties in dealing with children with IIH, especially in terms of the procedural aspect. But again, it comes down to discussion with parents, understanding the patient, and having experienced doctors, and that includes a neurologist, ophthalmologist, surgeon. Technically, venous sinus stenting can be done without difficulty. So in children, when they're under anesthesia, the procedure is not any different from the adults. And in children that are 7 or 8 years of age, the blood vessel size is really not different than adults. The head grows much faster than the rest of the body. So in children that are 7 or 8 years of age, the procedure is not any different than a 28-year-old. The decision-making is more difficult, but not the technical aspect of the procedure. So it is an option for children who do not tolerate or do not do well with medications. But again, experience is limited and the decision-making process is more complex. This is a series of pediatric patients we published like a year ago or less than a year ago, which was one of 2 papers that are discussing venous sinus stenting in pediatric patients. And this was, that included 8 patients at the time. Since then, I've treated more patients, actually more than 12. That slide is from like a month ago. It's like 13 patients now that I have treated, younger than 18 years of age. The youngest was at 4 years old. I have also treated a 2-year-old, but that was with stenting, that was for a thrombosis. So it was a different patient population than IIH. But for IIH patients, I have treated as young as 4 years old. Most of all these children were destined to have a shunt because they failed medical management. And 3 children had already had prior surgeries. All of them had shunts done before. 1 had cranial expansion surgery, and the rest, this will be like the first line surgical treatment. 5 children had papilledema, and it resolved in all 5. 3 had double vision, medical term is diplopia, and resolved in all 3. And 12 children all 12 had severe headaches, and it resolved in 11 out of 12, or nearly, I should say, nearly resolved or completely resolved. And there was one of these 12 children that were not able to help with stenting in terms of the headaches, and then ended up having a shunt afterwards from one of my good colleagues, and that did not help either. So it's possible that the headaches were not really related with IIH. But overall, I think the results in children we want the results in children to be perfect, just because we are always more sensitive as doctors also when are dealing with children. And we want, obviously, the best possible outcome for our patients, but especially for children. So these results are relatively, I would say actually very good results, but yes, I wish, we could help everybody with headaches, but as in adults, sometimes is not feasible. There was no serious adverse events, and the procedures were done without any problems. I did not put a slide here, but the antiplatelet agents essentially is the same as adults. The follow-up is the same, MRI scans, and there's really nothing different in the aftercare of venous stenting in children. These are 2 examples of that of our that were published in our paper. One is on the left-hand side of the screen. We're seeing the typical intrinsic stenosis, very focal filling, essentially defect in the transverse sinus from a large arachnoid granulation. And you see on the angiogram here that the contrast is dark, but in this area where the white arrow is, there is essentially no flow because of, or limited flow because of the granulation. And this is the stent positioning, and the post-stent angiogram shows no residual narrowing after stenting. And on the right hand side, we have the long segment extrinsic stenosis. So similar to adults, you can have this kind of general two categories of narrowing. And you see the angiogram here shows really long segment stenosis of the sinus here also on the lateral view. And after stenting, there is a robust flow into the treated vein. So similar devices and similar technique as adults. In terms of the internal jugular veins, this is even more elusive concept. But we know from patients, historically from patients who had either surgical removal of the internal jugular veins because of neck cancer surgery, or patients with thrombosis of the internal jugular veins, let's say from like central catheters, that are necessary for, certain treatments. And because of a catheter in being in the internal jugular vein for weeks and months, it could be thrombosis developing, or from trauma, occlusion of the internal jugular vein from trauma. We know historically that these patients may develop high intracranial pressure and all the symptoms that are similar to IIH, papilledema, positional headaches, etc. So the idea of internal jugular vein narrowing compromising venous outflow is not new. This is difficult, however, to apply this into IIH for two reasons. Or three reasons. One is that the vein is not occluded, but is narrowed. If it was completely occluded, then it will probably easier to pinpoint to the internal jugular vein occlusion as the cause of high pressure in the head. But since we're dealing with stenosis here, the problem is that there is physiologic narrowing of the internal jugular veins in the neck with neck movements, mostly moving the head and neck right, left, but also up, down, like extension and flexion of the neck, even with like breathing patterns, even with like, different body types. And in addition to the neck movement, and there is also a physiologic change in the caliber of the internal jugular veins with changes in posture, like being flat versus being upright. So that makes it difficult sometimes to quantify whether a stenosis that you see on an MRI scan or a CAT scan or even an angiogram is truly the source of the high pressure in the head. Again, sometimes it can be obvious, and other times it's difficult to be sure whether this is part of the physiologic spectrum of jugular vein stenosis as opposed to the something pathologic that causes high pressure in the head. This is like I copied this from the internet. This is showing the superior sagittal sinus in the head, the transverse and sigmoid sinus in the lower part of the skull, and there is the jugular foramen where the sigmoid sinus becomes jugular vein as the jugular vein travels into the neck to go to the chest. So it travels between the mastoid bone, the cervical spine, the jawbone, and another small bone here called the styloid process. So the internal jugular vein is surrounded by bones and muscles. That's another view here. The internal jugular vein in proximity to the cervical spine, in proximity to the jawbone, and this is the styloid process, which is a normal bone that exists in the skull. is usually short and thin, and is connected with a ligament, like a soft tissue ligament to the hyoid bone. This is a bone in the mid neck area. The styloid process can sometimes be thicker or longer or both, and impinge on blood vessels like the carotid artery, which is the red vessel here. And also, to add to this ligament can also be either thicker than it should be, or more directed, more medially, pressing on the vein also. So this can be a source of jugular vein stenosis, whether it's the styloid process, the ligament, or the cervical spine, or all of them. So this is the combination of these bones, whether they are like larger than they should be, or bigger than they should be, larger than they should be, or deviated more medially, they can cause impingement on the internal jugular vein. And this is becoming more and more known these days when we work up these patients, when we don't see evidence of severe intracranial venous stenosis, but we see evidence of stenosis in the internal jugular vein, then we have to have this in mind. The workup for internal jugular vein stenosis, I think the primary tool of non-invasive imaging is CT angiogram, and it's called angiogram because typically it's to look at the arteries, like the carotid arteries, but we can ask for what is called a venous phase. So this is like a little more delayed timing from the contrast injection, so that we can see the internal jugular vein clearly. And the advantage of the CAT scan is that we see the bones very clearly. You can see the C1 vertebra, which is typically the bone of the cervical spine that is involved in pressing against the jugular vein from the inside, like in the medial aspect. And the styloid process that we just discussed is on the outer part of the internal jugular vein. So we can see these two very clearly on a CAT scan. Is usually not clearly seen on the MRI scan. And we can get a sense of whether there is impingement of the internal jugular vein from the CAT scan. And the next step would actually be to try and quantify this and look at this in more detail by doing a venogram, a catheter venogram, and manometry. This is like my typical manometry paper. Like during the procedure, we take notes of different pressures, and we have the intracranial aspect of the venous pressures here. And on a patient who's going to be treated with stent, you have like the pre-stent measurements and the post-stent measurements. But also we're looking sometimes, depending on the scenario, at the internal jugular vein. And you see here, we're measuring upper and mid internal jugular vein if we're looking for impingement from the C1 and styloid process. So we're looking at, at the upper level and the lower level, and we look at different neck positions or head rotation positions, because things change from the head straight, head to the right, head to the left. So we have to do all these measurements in order to understand in more detail what is how significant the narrowing is and how it affects the venous outflow. So the workup is not as quote unquote simple as the intracranial stenosis, the venous sinus stenosis. And we still, even there's like, I think there's like 3 centers in the country that are working on this right now. I think we haven't reached a consensus yet, or we don't have enough experience even collectively to know exactly what threshold we need or what gradient we need. So it's a lot of still some guesswork in this decision, but we're we're gaining more experience, and I can assure you, I talked to my colleagues from other institutions, and we tried to come up with a consensus. So there's more work to be done, but we also recognize more and more the importance of internal jugular vein stenosis and high pressure in the head. This is an example from on a CAT scan that you see. This is the C1 vertebra, is like a ring, and this is what is called the lateral mass or the lateral process of C1 that is impinging on the jugular vein. You see the jugular vein at this level is like a pancake, it's very flattened, and a little lower you see how this is the same patient, the same scan. A little lower you see how open the internal jugular vein is. This is the same, again, the same picture, the same patient looking from sideways, what is called a sagittal view. And we see the same bone, the C1 lateral mass. This is exactly this bone here. We see it here, how it's impinging the internal jugular vein at this level, and below it's widely patent. This is a separate example of a patient where the internal jugular vein is severely narrowed. As you see here, it's like a flattened, and it's impinged on the outside from the red arrow. The red arrow points on the vein. The yellow arrow points on the styloid process. Is that round structure? Is the styloid process on the outside of the internal jugular vein, and the C1 lateral mass is on the medial aspect of the jugular vein, and the combination of the two flattens the internal jugular vein. Same patient. This is a coronal view looking like Athos. You see the elongated styloid process, thick and long, and the C1 lateral mass impinging on the internal jugular vein. So there's different scenarios and different degrees of whether it's C1 versus the styloid process. I think for the most part, the C1 is almost always involved, and the styloid process is, less frequently involved. And I think, at least in our center, we are, if we're going to recommend surgical decompression for the internal jugular vein, the C1 lateral mass is always involved, always resected. This is an angiogram that shows that the superior sagittal sinus and the transverse and sigmoid sinuses are normal without any narrowing. You see it on the lateral view, pristine view of the intracranial veins. But once you get into the upper neck, you see how narrowed the internal jugular vein is. This is like the normal, and this is the level of the narrowing. This is at the C1 level. We don't see the bone on this view here because everything is subtracted to show the blood vessels. But this is at the level of C1, and is not very different from what we see on this view here. On the CAT scan binogram. The difference between the angiogram and the CAT scan is that on the angiogram, we can make measurements like manometry, measurements of pressure in the vein above and below the narrowing, and also assess how these things change with the head straight, head to the right, head to the left, extended, flexed, and different neck positions. Sometimes even the breathing pattern can affect this. So it's important to have like a dynamic assessment, unless something is so obvious that you don't need to do too much of dynamic testing. But sometimes dynamic testing, or most times dynamic testing is important. This is a patient with jugular vein stenosis on a CAT scan, and you see with the head straight, this is looking the two views. Our angiograms are typically what is called biplane, meaning we're looking at two like a frontal view and a lateral view. So we're looking at the same time. We're getting two images, the frontal and the lateral, and you see with the head straight, there is stenosis of the jugular vein. I would call this like moderate to severe. But when the patient turns the head to the left, essentially this becomes almost occlusive. It barely fits the catheter, which is, again, these guys are like a spaghetti 10, right? So they're very small and thin. So turning the head can affect these measurements and the narrowing tremendously. The other thing that you see here is that when the stenosis is moderate, most of the blood flows downstream into the internal jugular vein. Less goes into collateral flow or other veins in the neck. When the narrowing becomes worse, you see there's a lot more blood flow into other veins in the soft tissues of the neck, like veins around the spinal cord, veins around the spine, and veins in the soft tissues of the neck, because the blood has to go somewhere, and if it cannot go down into the jugular vein, we have to find other ways, even if they are not as prominent, but it cannot be just stagnant. So this is also like another way of assessing how severe the narrowing is. So in terms of treatment, even though I advocated venous sinus stenting, for many years, I also advocated against internal jugular stenting for many years, because if there is bone pressing against the jugular vein, like the styloid process and the C1, and a stent is placed inside the vein, things may improve, but the improvement will be, I think, transient because the bones will still continue to press against the vein. The bones are not going to go anywhere, and the stent is not going to spread these bones apart. So eventually what will happen over weeks or months, but it will definitely happen, is that the stent, which is metallic but is soft and flexible, so it's not like rigid metal, it's like it's a flexible device. Eventually the stent will be crushed and possibly broken from the constant stress of the bones compressing the vein and the stent inside the vein. So I refused, in my career, to do venous sinus stent. I mean, I could never say that. I refused in my career to do internal jugular venous stenting unless there is first surgery to remove the bones that are pressing against the internal jugular vein. Now, the surgical decompression, as it's called, may sometimes not work because the vein may remain collapsed even if the bone pressing against the vein is removed. And that can happen because there can be adhesions on the on the wall of the jugular vein, or there are also muscles in the area that can continue to compress the internal jugular vein. But if the bones are removed and the jugular vein is still compressed and narrowed, then stent becomes an option because the stent will expand and there is no risk of the stent being crushed or fractured because of the bones pressing against it continuously. So stenting is an option after surgical removal of the part of the bone that is pressing against the vein. The last topic before we go to questions that you submitted is the topic of CSF leak and IIH. This is also an elusive situation and takes a lot of experience, a lot of listening to the patient, and a lot of thinking outside the box to get to the point where you can put things together for some patients that have like really complex history of non-specific symptoms. So what is the CSF leak is a tear in the membrane. The membrane is called dura that surrounds the brain and spinal cord and contains the CSF. The CSF leaks can happen in the skull, and typically these are like in the nose area, in the ethmoidal region. So the patients typically present with leakage of fluid through the nose or in the back of their throat, and it's a clear liquid fluid, and it can be analyzed to be confirmed whether this is actual CSF or just like mucus secretion. But they can also occur anywhere in the spine, and they can be identified in the spine by specialized MRI scans or by injecting dye with a spinal tap type procedure, injecting dye and doing something called myelogram, and look for areas where the contrast will leak outside the CSF, outside the fecal sac. Patients who are at the risk factors for developing CSF leaks are the connective tissue disorders, are the ones we understand well. So patients with Ehlers-Danlos loss, for example, are at risk for CSF leaks. The symptoms are non-specific, except perhaps for the typical headaches, which are worse when sitting up or standing up, and improved when lying down. In other words, when patients lie down, the pressure in the CSF space tends to normalize, as opposed to when they're like sitting or standing up, when the pressure tends to decrease. There are multiple vision changes. Patients present with different types of vision changes that are not very different from IIH, sometimes blurry vision, double vision, and visual field loss. Hearing loss, tinnitus, typically non-pulsatile, like the ringing type tinnitus. Sensitivity to light and sound, imbalance, neck pain and stiffness, nausea, vomiting, and back pain, especially for the CSF leak patients. The CSF leak and IIH can be associated because some patients with IIH may lead, in some patients, IIH will lead to CSF leak as the pressure is increased, will lead to a tear in the dura, which on one hand will decompress the high pressure and protect the patient from developing papilledema, for example. But at the same time will cause a low intracranial pressure situation, like a CSF leak type symptoms. So IIH may manifest with CSF leak. So it's important in the history of a patient that is being worked up with CSF leak or in the imaging findings to look for signs that would point towards the IIH being the fundamental problem. Like the original problem is IIH and CSF leak is the secondary problem. And then what happens is many patients, they go into these cycles of high and low pressure, meaning that initially high pressure leads to CSF leak, and then over time, CSF leak can be self-treated. This happens a lot, like just with time, the CSF leak can repair itself, and then will lead to high pressure again over time, which eventually will lead to another cycle of CSF leak. Or what can happen is by treating the CSF leak, like by what is called like a large volume spinal tap, or like a glue injection or thrombin injection, or surgical repair for the scalp-based CSF leak, then you create again the substrate for pressure to increase because the cause of the high pressure in the air has not been removed. So after repairing the CSF leak, the pressure will rise again, and then the patient is at risk for another CSF leak. So, this is something that is, again, we're getting better at this, understanding this better. a few specialists will talk to each other and try to learn from each other's experience. But there are patients out there with CSF leak that the fundamental problem is actually intracranial hypertension. And they should be considered for IIH treatment. Medical management always has a role, but if medical management does not work or is not tolerated, or if the evidence of there is evidence of rapidly increasing pressure after CSF leak repair, and they have venous sinus stenosis, they should be considered for venous sinus stenting, because the idea is that by doing venous sinus stenting, you prevent the surgence of high intracranial pressure, which would prevent the CSF leak from occurring again. So eventually you try to maintain the patients in a normal range of high intracranial pressure, normal range of intracranial pressure without going very high, leading to CSF leak, and then going very low. So this is something we understand more and more over time, and we should be considering this for patients who have the presentation of low ICP headaches or alternating low and high ICP. ICP, when I say ICP, I mean intracranial pressure headaches. Again, it's a elusive concept, is not very clearly defined yet, and we rely on patient history, patient symptoms, imaging, and in our experience. This basically concludes the what I wanted to discuss as kind of like wrap things up in terms of venous stenting. I received a lot of questions, and I chose some that were not very personal in terms of information, or I modified them so we can discuss.
Dr. Patsalides, before you begin, we just had a question regarding CSF leaks. Someone asked, what about lupus? Is that considered a connective tissue disorder that can put one at a higher risk for CSF leaks?
I don't think that lupus is something we consider higher risk than usual for CSF leak. I think we're talking more about Ehlers-Danlos and more connective tissue disorder rather than autoimmune diseases like lupus. All right. So question, there were several unwanted outcomes. I think it's an important topic in the research that I discussed about stent trials. And if a patient were to get like a hemorrhage or other effects from the stent, are these fixable? Do you address these problems after surgery, or are you passed on to some other doctor? I think that's very important. I showed, and I have this, what I showed and what I presented to you is basically what I say in the patient in the office, that there is never a zero risk of a procedure to be done in the head. The most important thing, or the most important aspect of a good outcome, is not to have a complication, because once a complication happens, the situation is difficult by definition. And even if we try to correct things, then it's just like there's no guarantee that things will be normal. So it's very, very important that everything is done so that the complication does not happen. I cannot say that any possible complication can be fixed, because that is not true. That's why I think it's important that when you are considering these treatments, look for physicians who have experience and track record, and they have shown that they're meticulous and careful. Almost all the problems that can happen in venous stenting will happen during the procedure or immediately after. And so it's very unlikely I cannot say impossible, but I say very, very unlikely that something would happen hours or days after the procedure if everything went perfect during the procedure. So again, we go back to the best prevention of problems is not to be in a problematic situation. So, it's better to invest more time during the procedure, to be more meticulous, more careful, and make sure that everything is going perfect so you don't deal with any problems after the procedure. And I'm not talking about the incisions, I'm not talking about like headache. We talk about this, many of these incisional pains and headaches are expected and part of the experience, but I'm talking about the hemorrhage, stroke, things that are like ominous, things that are like lead to disability or death. The best outcome is not to deal with these situations. But risks exist, problems happen. My experience is exceptional, but there are possible things. Things can go possibly wrong, and that's important to choose your doctors carefully. This is a question about a shunt that I haven't discussed shunts yet. This is something I'm going to discuss after summer with one of my colleagues. I would say one of the big differences between stents and shunts in terms of after is that it's very difficult to manage a shunt if you are not close to the patient, because the shunts require a lot of changes in the settings. They require a lot of troubleshooting, often require like revisions. So I would not advocate somebody flying, from Arizona to come here in New York to have a shunt, because I think even if everything goes perfect, there's a good chance that in the next few months something needs to be, troubleshoot. So I would say for shunts is much more beneficial to have local doctor or somewhere you can go easily, as opposed to the stents. I think that the chance of a revision, as we said, or a redo is in 13% over many years. That is my experience. And the aftercare is really not that complex, and can be, there is really not much to do unless you are the unusual patient who needs a revision. So with the stents, I am personally very comfortable managing patients from out of state, and I think that's a big difference between shunts and stents, in addition to the technicalities and invasiveness, et cetera, et cetera. So the long-term follow-up, I do it remotely. It can be done with local MRI scans, sent for review, discussion of symptoms, discussion of antiplatelet medications. I don't necessarily bring patients back to New York for follow-up. So that's that. That's actually another great question. An opening pressure on spinal tap is normal, but the patient still has significant headache and has a stent already. I think that is a scenario that is, difficult to be definitive. There are pitfalls with the spinal taps and opening pressure measurements. And I think if there is concern for recurrent pressure or residual pressure causing headaches after stenting, the answer is to do a venogram and check pressures. And I think that is probably the more accurate way of assessing things, rather than rely necessarily on a spinal tap. Again, there is no definitive way of doing things. If there is discordance between a spinal tap and the patient's symptoms, in somebody who had a stent in place, venogram, manometry becomes very important. I use steroids and pain medications after surgery, and that is routine. Can steroids be avoided? Yes, if somebody has no headache after the procedure, I would not give steroids. Or people who have like bad reactions to steroids, like feeling like overactive or feeling like agitated with steroids. The steroids are not absolutely necessary. They are a way of decreasing the post-stent headache, but it's not by means absolutely necessary. So this can be avoided, no, absolutely. Regarding blood thinners, is this something that has to be on for the rest of their life or only for 6 to 12 months? So there are different ways to do this by different groups. But for me, it's only between 6 and 12 months. You don't need to be on blood thinner beyond 12 months. I prefer not to stop it earlier than 6 months, but somewhere between 6 and 12 months. I prefer 12 months because it's easy, but if a patient is getting pregnant or there's other reasons, I'm comfortable discontinuing it after 6 months, but I would rather 12 months, but not more than 12 months. Other physicians have different requirements. People who have gastric bypass for weight loss and they cannot use anti-inflammatories or aspirin following surgery. Is this an obstacle for treatment? Yes, we have to take this into consideration. There are options for blood thinners that are compatible with gastric bypass surgery. And there are options for non-steroidal anti-inflammatories for the immediate post-procedure. For example, we can give them intravenously in the immediate post-stenting period. And we can use other types of pain medications if necessary after stenting. So gastric bypass is not a problem for having venous stenting if that is necessary. So that is a good question. What number does the gradient have to be for somebody to be a candidate for a stent? And I discussed this. My typical threshold is 8. And it can be less than that if there is a very recent spinal tap, because then you expect like the pressure to be, or the gradient to be less than typical with a recent spinal tap. So I would say 8 with some exceptions. Again, there are different numbers in the literature between 4 and 10. I think 8 is a reasonable number that gives us enough assurance that we're doing the right type of procedure without excluding patients that would need it. So how long do you typically see your patients after stenting have vision, restoring vision after the stent? There's no magic number. I would say that there should be improvement of the papilledema within a few weeks. Is definitely not immediate. Even if vision starts improving, like blurry vision often improves from the first day, or double vision improves from the first few days. The actual papilledema takes more time to improve, and I would say within a few weeks. But that also depends on the duration of papilledema over time and how it has affected vision already. So there is no single answer across the board. This is more like it depends on patient. It's patient specific. But again, for most patients with papilledema, I would say within a few weeks there should be improvements. What if there is a recall? Is the stent removable? The answer is no. The stent is not removable. So, and that is a risk with any implant, whether it's a coronary stent or a venous sinus stent, or like a cardiac valve or what have you. The chances of of a recall of an implant, I think statistically if we look at the FDA records, is at least for the stents that or other implants that are used for other treatments are traditionally very, very rare. But yes, the stent will not be removed. On the other hand, within a few months, the stent becomes less of a foreign body because it gets incorporated into the wall of the vein. That's why I'm comfortable stopping blood thinners at the year mark or even at the 6 months mark. So it becomes embedded in the wall of the vein, and it's less of a risk of causing a foreign body reaction, of causing any type of problem. So yes, there is always a consideration for implants, but I think the risk of a recall is very low, but definitely the stent cannot be removed. Can jugular vein stenosis be seen with the brain MRV? Yes, it can be seen, or it can be suspected with the brain MRV. That's like in the lower part of the images. And if this is a suspicion from the brain MRV, it has to be followed with either a neck MRV. As I said earlier, I think if you're going to go for a scan specifically for jugular vein stenosis, the CT venogram is better because it will show the bony details that are necessary to understand the problem better. Is the pressure gradient with the patient under sedation higher or lower from local anesthetic? It can be both, because sedation on one hand, could lead to lower pressure system in the head, just because the patient is relaxed. On the other hand, it can affect the breathing pattern, especially like in larger bodies, in a way that actually leads to higher pressure in the head. So it can be inaccurate on both directions. That's why it's much more important than either sedation is minimal, like just at the beginning of the procedure to remove the anxiety. And it's important that at the time of the measurements, the patient is wide awake and has a conversation about his favorite TV show or movie or work and family, So I want the patient to be able to have a conversation at the time of the measurements. So yes, ideally under local anesthetic only. How long should you wait after CSF repair with Spinal Tap to do an angiogram? I guess it depends on the extent of the CSF leak. I think if this was like a surgical repair, I would probably say within a few weeks, if more like closer to the month. If this was like a small CSF leak and it was repaired with a blood patch or with a glue injection, I think I've seen patients that needed stenting within a few days because the symptoms rapidly surged. But I would probably say within a couple of weeks is reasonable. So in general, I would say 2 to 4 weeks, depending on the extent of the CSF leak. When should you stop taking a diuretic before the venogram? I don't necessarily recommend stopping medications for patients, especially if patients have papilledema, because you don't really want to take any risk of making things worse in terms of vision. So I, for the most part, keep the medications, the usual medications during the venogram and stenting. I don't require that we stop the medications. Is it possible to have a stent placed if you have dural venous sinus thrombosis? Yes, absolutely. I think it's an excellent treatment to have stenting. If there is need to improve venous outflow, compromised by thrombosis. So it's challenging, and it's not something that is often done, because you have to, instead of like going through an open vein that is narrowed but patent and place a stent, you actually have to go through a clot, open the clot, create a channel, and then pass the stent. So it's a more complex procedure than the typical venous stenting, but I have used it for patients with acute thrombosis and also for patients with chronic thrombosis. So in the right setting, like in a patient with symptomatic from the thrombosis, stent can be done. A clotting disorder, that really depends on the clotting disorder and whether it has caused stroke, it has caused like clotting in the vein, clotting in other parts of the body. I think the answer is stenting can be done. Probably need to be more aggressive with the antiplatelets and including like a third blood thinner in the short term, maybe for like 2 to 4 weeks. So yes, there is a special consideration, a little more discussion with the patient, discussion with the hematologist who is following the patient, I presume. But a clotting disorder does not exclude the patient from having a venous stent. But again, it becomes like a little more complex procedure in terms of the management of blood thinners. Are more stents close to each other required for long stenosis or for intrinsic stenosis? And I think I discussed this in all the earlier talks. Longer stenosis ideally should be treated with longer stent construct, which often requires like more than one stent. And that is the extrinsic stenosis. For the intrinsic stenosis, which is typically a short segment stenosis, a short stent is typically enough. So the length of the stent should definitely match the length of the stenosis and a little beyond that. Is there an alternative to a lumbar puncture to see if intracranial pressure has increased? I mean, yes and no. If somebody has papilledema, obviously we have a very good surrogate marker of increased intracranial pressure. Or severe wrist stenosis, adjacent to a stent in a patient who has been treated with stent and the veins were like normal before. So there are these indirect evidence that we use of increased intracranial pressure as increased intracranial pressure markers. But if we want to put a number to this, the only way to do this today is a lumbar puncture. There are ideas for non-invasive measurements by measuring like pressure on the tympanic membrane, by measuring fluid dynamics with MRI, but nothing really to the point that we can actually have a patient today and say, go get this scan instead of like a lumbar puncture. So for now, the only direct way is a lumbar puncture or like a monitor in the head, like what's called a bolt monitor, like a minor device in the head, measuring pressure in the brain parenchyma that requires like a minor surgical procedure. So these are the two ways of putting a number in the intracranial pressure, and everything else is indirect. Is stenting considered when patient is tolerating Diamox, but symptoms of static and pulsatile tinnitus continue to worsen? The answer is, in selected patients, yes. The venous stenosis will be causing the pulsatile tinnitus. The static tinnitus is probably like a consequence of the Diamox rather than the venous stenosis. So again, this is really not a, one answer fits everybody scenario. I think it's a discussion about the specifics for each patient, but the in general, I would say in my clinic, I would consider this and have a proper discussion with the patient. Is age a significant factor for positive outcomes with stenting? The answer is no. If stenting in a transverse sinus is completed and there is some narrowing in the jugular vein, could that cause intracranial pressure? The answer is yes, it's possible. Again, it goes down to the assessment of the narrowing and decisions about that. Would both need stenting? Possibly, but again, as I said, the first option, at least in my view, of jugular vein stenosis is surgical decompression, removal of the bone that is pressing against the vein, and stenting should follow if necessary. If imaging does not specify extrinsic or intrinsic, is there a way that this is self-evident? I think in the expert eyes, I think this is evident. It's very rarely that the MRV or CTV report will specify that. I mean, it's rare that they will even say there is stenosis. So I don't think I've seen ever a report that says intrinsic or intrinsic stenosis. I think, I'm surprised when I even see venous stenosis on the report. So I think we have, I think really relies on the expert eyes. If there is severe bilateral transverse sinus stenosis with suspected craniocervical instability, will stenting still be helpful? It depends. Depends what symptoms we're going after. If we're going after typical symptoms of high pressure, like papilledema or pulsatile tinnitus, I think the answer is yes. If we're going after neck pain, occipital headache, nausea, kind of like less symptoms like less typical of high pressure, I think we have to decide between treatment of the craniocervical instability first and then consider stenting. So it's one of these situations that I think discussion between the patient and the team of experts becomes important, because there is no simple or consistent answer here. It really depends on the patient, the symptoms, and the findings on the scans and the exam. Do you know how pediatric patients do with stents into adulthood? Yes and no. We know the experience is limited. I think, I presented my experience, and there was another study from a few hospitals together discussing pediatric patients, and I think we would still consider this like limited experience. But I would go back to what I said, in a 7-8-year-old patient, things are not drastically different than adults in terms of blood vessels in the head. So so that kind of I think gives us a lot of reassurance on how things will evolve as the kid continues to grow. I would not anticipate any problems. And in the younger patients that I treated, many of them were treated years ago, and obviously I still follow them, and I don't see any problems with because of the stenting. The narrowed part of the vein remains, conforms to the stent, and the normal part of the vein continues to grow, but it doesn't grow out of proportion to the stented part. So there is I haven't seen an issue yet, but I'm also not casual about this. It takes a lot of thinking and a lot of consideration with the parents and the patient to reach the point of stenting for a pediatric patient. What happens if the stent doesn't stay open during insertion? what the next step would be in those cases. I would call it like a catastrophic scenario. And really the only thing you can do is either try to remove the stent if that's possible. It's possible to remove a stent if it's not expanded, but that's by no means simple. The other thing that can be done is advance a balloon inside the stent and gently try to inflate the balloon to inflate, to expand the stent. These are the two things that can be done, and hopefully, no patient has to be in that situation. All right, this is the end of this slideshow. Hopefully, I didn't go much longer, and I think this concludes the first series of the 3 webinars, or the 3 educational talks. I think my next presentation will be in September, and we will start discussing other aspects of IIH, like the ophthalmological findings, shunts, like bariatric surgery, and obviously in between those, I would be happy to have a session just to discuss concerns or questions that people submit. So we will come up with a schedule for September and beyond, and we'll continue to do this because I think it's there is interest from the patients, and there is certainly interest from me to continue this. So I wish everybody a good summer, and be back in September. Have a good night.
Dr. Patsalides, for spearheading this for you guys. We really do appreciate all of your gratitude, and we appreciate Dr. Patsalides for taking the time. We know it takes a lot of effort and a lot of time to set this up. I know that a lot of you sent other questions. I will be sending a list to Dr. Patsalides, and again, we will formulate another list, and he will go through those questions. So please know that I did see your questions in the chat. I know we can go on and on, but we will collect those questions and we will utilize them for the next session. Again, just a reminder, if you are interested in that therapeutic support group, my plan is for July 6th, again, on a Tuesday, 5 p.m. Eastern Standard Time. So it'll be easy for you guys to remember. If you are interested in that group, I'm going to try to keep it into a smaller group, but I want to make sure you're all still involved and included. So if it's a little bit bigger, we'll try to, maybe I'll separate into other groups, individualized sessions. We'll try to figure something out. But if you're interested, email me in those emails, the IIH support at northwell.edu and gmauro@northwell.edu. I'm going to send it to you guys one more time, just in case you did not receive it. But of course, most of you have my email. You know how to find me. So don't be shy. I know most of you are not shy. So please let us know if you need anything. We're here to support you. Thank you, Dr. Patsalides.
If anything I learned all these years is that the IIH patients are not shy. So,
right?
So I'm not worried about.
Well, we'd rather you guys be open than not share your concerns. So we appreciate you all. And thank you, Dr. Patsalides, so much for everything that you do. All right, guys. Thank you so much.
Thank you, everybody. Have a good night.
Bye, guys.